focused really around two things that came together for me, which was at a policy level being involved in the Protecting Victoria's Vulnerable Children inquiry, terrible mouthful, as one of the panel members, and the other was something I've been doing since retirement, which is clinical group supervision with what in Victoria we call maternal and child health nurses, across Australia called child and family health nurses, and here called CHAPs, right? So you think CHAPs when I talk maternal and child health, but I've used the generic term there. So I'll run through this really quickly because I think it's important to get the policy context. So child and family health nurses are quite distinctive in having both. Oh, how many child and family health nurses have we got with us? How many CHAPs?
They are known as child and family
health nurses. Right. It's the service that's called CHAPs, but you're child and family health nurses. So, so we've got you with us. You're one of the few professional groups that have both a child and the parent as your unit of attention. Most services will dichotomise either the child or the adult. So I think this is a very special service. And I've borrowed the Adelaide Women's and Children's Hospital logo, and I'll talk more about that tomorrow and tell a longer story about it. I want to start with really confronting data, which is a more than doubling of Australian children in state care in the last decade. And I haven't got time to go into it, but the very concerning US research, we haven't got any Australian research which can illuminate this question, which is suggesting in fact that for many children who come into state care, they can be further harmed by that experience. So that is really to remind us about what we have to do to stop that trajectory continuing. And if we look at the characteristics of children coming into state care, and this is a recent national study in which Tasmania was involved, but this is generic national data, aggregate data, we can see very high percentages, around 2/3 of children coming into out-of-home care have at least one parent with an alcohol or other drug problem, have experienced domestic violence, or have parental mental health problems. And of course they sum to more than 100%, because often there are multiple and complex needs. And yet we have a service system which is largely built on single input services based on categorical funding. Terribly bureaucratic phrase, but captures, I think, nicely how narrow some of our services are, that they deal with only one member of a family or one bit of one problem of one family member, when in fact the families we need to work with to prevent children coming into care particularly have multiple and complex needs. And so engagement of parents remains a major challenge, and relationship-based practice is greatly diminished when you've got families involved with a large number of organisations in often a revolving door of referrals, which don't necessarily result in a service. The challenge of ending child abuse is the challenge of breaking the link between adults' problems and children's pain. I think it's a profound statement, and if our services are not working on the adults' problems that cause children's pain, they're not actually achieving the vision we have for children. So how do we take the first steps? Well, and I'll talk more about this tomorrow when I talk about collaboration, but we need to strengthen all that's in the blue to reduce the pressures and to reduce the number of children coming into contact with our statutory child protection services, and even more so coming into placement. And so child and family health nurses are vital in the outer two blue circles, in that it's a universal service, but increasingly across Australia is a platform for reaching more vulnerable families. The See You at Home initiative, some of you might be involved with, is an example of a child and family health nurse program here in Tasmania in the second blue circle, the targeted prevention and intervention for vulnerable families. So in our Victorian inquiry, not surprisingly, amongst it over 900 pages, almost 1,000 pages, we recommended increased investment in Victorian language, maternal and child health, and enhanced maternal and child health. That's where a maternal and child health nurse works exclusively with vulnerable families, and I understand the system in Tasmania is different, where the universal nurses may have as part of their caseload vulnerable families. So a different model, and an interestingly different model. And we also wanted greater emphasis on engagement pre-birth, which in Tasmania is already the case, and a more intensive program of outreach. Victorian data on follow-through of the service to 18 months and 3 years is significantly better than that in Tasmania, but we still think that we've got a long way to go in terms of outreach to families, and there's still a tapering off by 18 months and 3.5 years. So this professional group has seen an astounding evolution from a paediatric surveillance model, which I call the 20th century model, weighing, measuring and immunising babies and screening for developmental disorders, to an early 21st century model which is bio, psycho and social. It does all that, they're vital functions, but in addition it's exploring the emotional and social well-being of parents and children as of equal importance. Obviously, massive implications for professional education and clinical supervision. And what we've seen in this professional group across Australia, perhaps more than most professional groups, is a shifting from the infant as the focus to truly seeing the infant, the young child and the child's family as part and parcel of the role. This came about of my work back in the 1980s with maternal and child health nurses in Victoria on the problem of postnatal depression. And some nurses were saying, it's not my concern. Some were saying, well, it's a concern, but it's someone else's job, I just refer on. The referrals often didn't get to their destination. Some were saying, well, it's not my core role, but I've got to do it because no one else is. And some were saying, a small minority, it's part and parcel of my job. And what we've seen in 3 decades is a shift to the 4th position. And that's indicative of, I think, what we need to do across a range of professions if we're going to play our roles in broader ways to meet the multiple needs of vulnerable families and not just that single input that we may be originally trained for or funded to do. So to do that, we need 3 levels of strategies. We need a policy context, which of course supports a broadened way of delivering your role. We need organisational settings which provide a reasonable caseload so you can perform a broader role. If you've got an impossible caseload, you'll have to narrow what you do for each family. So even if you've got the values, knowledge and skills to perform a broader role, you won't be able to do it. And service providers, how do we actually help people in both their pre-qualifying training and their post-qualifying training to be able to perform this broader role with vulnerable families. So I'm talking about a triangle of values, knowledge and skills. And I really put the values down the bottom. It's easier to convey knowledge and skills than it is to really change values. And yet, when we talk with those using our services, it's often the values of the service provider and the emotions that they have in relation to the service provider's values that make it possible to use the service or not. So it's a fear of being judged, looked down upon. It's wanting to feel respected. And so it's the value basis which I think is what makes it hard for many vulnerable families to use the range of services available. And if we're working in a relationship-based way, it seems to me that the 4 core elements for the service provider are empathy, respect, genuineness and optimism. I'm not one for acronyms, but I like this one because it adds up to ERGO. And they're really easy to read off a page like I've just done. But they don't flow well unless we, as the instrument of our own practice, is doing well. So we're like a musical instrument. If we are working in this way, conveying these values and these emotions, then we need ways in which we can look after the instrument of our own practice. And that's where the clinical supervision comes in. Before I move on to that, I just wanted to put this into a research context. This is about psychotherapy. It comes from a meta-analysis by Lambert, emphasising the importance of the quality of the therapeutic relationship. So doing an analysis of many, many studies and trying to draw from them what are the factors which are associated with positive outcome. And I don't think we can immediately extrapolate from psychotherapy to working with vulnerable families, but I think that it's a useful hypothesis that we might be able to do so. So Lambert concluded that 40% of positive change related to client factors such as personality and environmental factors like social support, 30% related to the qualities of the therapeutic relationship, the empathy, the respect, the genuineness and the optimism as experienced by those using our services, and 15% to hope and expectancy of positive outcome. So to what degree are we the instruments of hope? And last but not least, but our professional journals are basically full of the last 15%, which is evidence-based practice. An evidence-based practice that's not taking on board the other 85% of the evidence about positive outcome, I think is slightly missing the main game, which is not, of course, to say that specific techniques are not very important in specific situations. From treating phobic anxiety, if we want to talk about psychological interventions, through to settling the hard-to-settle baby, it is very important to have specific techniques to match specific situations. So, as I've already posed this question, how do we create clinical supervision so that it helps support the service provider have those values and virtues? How do we help share the practice wisdom or clinical judgment, which comes not directly from research, but comes from day-to-day experience? And what sustains us in our work with families? And that's the bit that leads to the importance of reflective clinical supervision. And the word supervision is absolutely wrong, but it's a tradition in the field of mental health and psychotherapy, so it's come down to a number of helping professions, but it's completely the wrong word because it's got a management, authoritarian connotation. And so the first thing is to really debunk the word. So some people talk about professional mentoring or a sounding board for reflection on one's practice, or in medicine it will be talked about a secondary consultation. This is not telling someone what to do. And in terms of relationship-based practice, it's giving people a safe and supportive environment in which they can reflect on themselves as an instrument of their own practice. So that has become increasingly important for child and family health nurses as their role has evolved from paediatric surveillance to the psychosocial dimensions of vulnerable families. And so we're now seeing in many places supervision, clinical supervision, being given emphasis in the practice of child and family health nurses. Of course, this has relevance to clinical supervision generally. And I've just identified there 6 factors that might help support the supervisor-supervisee relationship. And the first one is empathy, respect, genuineness and optimism. If you think about the best sounding board for reflection upon practice, clinical supervision, call it what you like, you've ever experienced, my guess is that it was done in a context where you perceived that there was empathy, respect, genuine interest in you and optimism. So this leads to the question, how does supervision embed those qualities, and how is that embedded in organisational life to support child and family health nurses, but really to support everyone who works with vulnerable children and their parents. The second is uninterrupted time. I did a study many years ago with people in the Child Protection Service in Victoria, and I did a survey with the supervisees and also the supervisors, and I asked them on a Likert scale to rate how frequently their supervisory sessions were interrupted. What was fascinating, as you might predict, is that the supervisees perceived the sessions to be interrupted at a far higher level of frequency than did the supervisors. And I think today, with emails coming through and text messages, in addition to the phone and the knock on the door, which was always the case, I would think if we were to repeat that survey today, we'd find that that finding was even strengthened. So I think it gives a very powerful message to the supervisee when you allow interruptions to occur. What you're really saying is that anything coming in that I give precedence to is more important than my being here for you. It's a bit like Steve having the television going and trying to have a deeper, meaningful conversation. It can't be done. So I think it's worth reflecting on the degree to which we're able to provide a space like that. The other thing in reflecting on supervision is the clarity of expectations. So what I've often suggested to people is that it might be helpful to start a supervisory relationship by trying to explore what we each think this thing called supervision is about, so that people don't feel, for example, that if you ask about their feelings in relation to a family, that you have overstepped the mark and are moving into an area where they're not really prepared to give you permission. So there's a conversation about what's on limits, what's off limits. And that's a tricky one when the supervisor is also the line manager. And very often in internal supervision, where the supervisor, the clinical supervisor, is the line manager, it's really difficult for both the supervisor and the supervisee to create that environment where they can really together look at the instrument of the supervisee's own practice. Not impossible, but there are authority issues there, particularly if that person might shape whether you get a renewal of your contract or also does your performance appraisal. So how do we deal with the authority elements that might come into this relationship, which is why in many places aspects of the supervision which don't challenge line management accountability, but external supervision provides a less complicated way of feeling safe and looking at some of those issues. So when I do facilitate clinical group supervision with child and family health nurses, I'm never usurping the line management authority. That must be really clear. But there's also the safety that what we're discussing is confidential and that I don't speak to management about any of the detail. I might talk about general themes with the permission of the group, but that it's a very confidential and safe place. So clarity of expectations. The mutuality of supervisory style. It's also helpful, I think, to ask each other, what's the best and worst supervision you've ever had? And what would you need to almost say, tell me what I shouldn't do as a supervisor. And often we'll find that if you go in your experience, you'll find that some people have felt directed and over-controlled and micromanaged before, and that that's going to be touchy for them if they have a style that's directive. And other people have felt really like they've had very laissez-faire permissive supervision that hasn't given them the level of direction they actually wanted, and they've been tossed in the deep end. So it really helps to, I think, have a conversation about what are we bringing to this, and how do we get some goodness of fit in the style. The other thing I think is really interesting from a supervisee's point of view is how willing the supervisor is to be my advocate, to manage up and not just manage down, if that person is in line management relationship. Or even with external supervision, I've been able to take back to management, with the permission of the group, issues that emerge for the nurses when there are rather sudden transfers of location of where they're working, which doesn't fit well with relationship-based practice. So it's been possible to feed some of those things back, as well, of course, to encourage them to feed that back themselves. So someone who's being a good supervisor is someone who's prepared to be an advocate. And last but not least, I think, is that regular review and reflection. So let's build it in so that in 3 months' time we do a bit of a stock take, see how this is working for you, whether we need to change to make it work for you more effectively, etc., etc. So there are a few points I had in mind. And I just wondered if you had any comments or reflections upon those. Done a lot of talking. I saw a few ums and nods, so I think some of those might have resonated with some people.
I'm just going to add regular planned meetings.
Absolutely.
Uninterrupted.
Yes, so I should have had there a regular schedule, so it's not catch you in the tea room, or if we happen to be...
Prepared.
Yes, yes, so it's...
Either way.
Yeah, and that needs to be built into the structure of the organisation. And if the work is with vulnerable families, then in the child and family and mental health settings, one would be talking about weekly supervision. And that's something that few child and family health nurses working with vulnerable families would have available to them. So you're very right, thank you for that. Someone else?
And to create, and to show that it's a really important thing too, because sometimes what happens in a lot of organisations is the pressure of what's coming in with the work means that you may have scheduled the supervision time, but it gets pushed constantly. And there's this real message around your need to have clinical supervision is not important. It takes secondary to the work of the client. But if it's back to front, you need to be bolstered every now and then to be able to do the best work that you can do.
Direct service demands will nearly always usurp the supervision, and again in our study in the Child Protection Service in Victoria quite a long time ago, that was also one of our findings, was the continual reschedule, and that has the same message as the interruptions. Very hard to do in a very pressured work environment.
This is talking about child and family health nurses.
Yes.
But it's also really good for other
Sure.
professions and other people that are dealing with vulnerable families as well. And I think it's kind of something that is in place for child and health nurses, but quite often isn't in place for other professions as well.
Were you thinking of particular groups where this may not be as available as it should be?
Yeah, well, just really across the board, but particularly with child and family centres as well.
Also IPS workers, family support workers.
Interesting, yeah.
IPS workers.
Yeah.
Yeah.
I think it comes down to what you pointed out earlier, which is social policy, and the one thing that wasn't on there was resources, and the fact that there seems to be a constant issue with enough resources so that we can do our jobs effectively. So our jobs always sort of get undermined, and with that things like supervision become secondary.
Yes.
And so in that you don't have effective service delivery, because at the core of everything seems to be money and resources and politics.
Yes. And that's that organisational context, that middle concentric circle in terms of resources, and the demand pressures are enormous. Even under high demand pressures, though, it can be very short-sighted to sacrifice one of the few ways in which we sustain the morale and the self-confidence and the self-care of our service providers. So I think that not recognising how central it is to demoralisation and staff turnover, and even from a purely monetary perspective, high staff turnover is very costly for an organisation.
That's a real challenge real challenge in an organisation where you're working with people who are not working in the welfare sector. For instance, I work as a social worker in Centrelink, and as an organisation there's KPIs and time limit standards, and you get things pumped out, and so there's this sense from all the other staff in the office that the things that are so important to social work, other than just casework, really shouldn't be happening. It's not important. It's a waste. It's a waste of time. So meetings and supervision and case consultation and peer support. That's all time wasting social working stuff that we shouldn't be doing. So it's real organisational.
It's not direct.
Should be doing those things.
Yes. Was there someone else?
Yeah, so I'm in the education department, and we have no supervision at all.
Yeah. And yet, are you in the classroom situation?
No.
Which role?
I work with all really high risk children across 3 different schools.
Wow.
We have no supervision.
That surprises me, because I would have thought in that setting that would have been built in.
Well, there's another
to the
teacher
structured
in front of me
service.
in a similar situation. I'm wondering if Sally has the same.
No, not so much. Yeah. It's a different sort of supervision that I get, because I'm still working under a principal, but because you've got 3 different schools, it's really tricky. So sometimes the lines get really blurred.
Yeah.
So you're not sure where you should get that support from and that supervision from.
That's really
and
important.
sometimes we fund it differently as well.
Yes.
So the programs Gail and I run at school, and Katrina isn't funded by the education department. So there's a grey area too about where that supervision comes in.
So it's quite blurred, and it can miss out entirely then.
Yeah.
Jeanette?
I sat in on another presentation a couple of weeks ago with a woman who offered professional supervision as part of the private business. And she talked very much about, as a professional, you have an individual responsibility to be seeking professional supervision if you're not receiving it through your workplace. And she spoke about it, I guess, in terms of in some ways, an health and safety sort of perspective, that, yourself is your tool, and you do need to be minimising stress. And I just wondered if you had any particular thoughts about, if it's not provided through an organisation, what your responsibility is as a professional.
My first thought is that it should be provided by the organisation, because it is part and parcel. If you're the instrument of your own practice, then I think your employer should be helping provide care for the instrument. But I think that it may be the only way to sustain yourself in some roles under some organisational conditions to seek that assistance. But I would think that there is an obligation on the part of an organisation to provide that. Yeah, would be my view. I don't know how others see that. Any other sort of points of reflection about some of these issues?
I think the quality of the supervision is very important. That you have someone who knows how to guide and support and improve that reflection, and, especially if it's a new practitioner, or even not a new practitioner, always keep reflecting and learning. And I have a friend who's had to look for another supervisor because there's, they just sort of can't work together effectively in that role.
And one of the difficulties is, I think, that the supervisor themselves carries with them their internalised models of supervision. If they've been highly directive, then it'll lead to a lot of advice giving, rather than a process of trying to draw out the supervisee in what their thoughts are about their work in this particular family situation, their responses, what they think the next step might be. So it's asking a lot for someone who hasn't experienced that style of supervision to be able to offer that. But it is possible through supervision, professional education, I think, to help. And I think we shouldn't expect that one supervisor can know about all the things that you might need to know about in working with vulnerable families, so that it might be that the supervisor's in a really good point to see across a number of service providers what are the needs. That do we as an agency need some additional training around family violence, or have we got access to secondary consultation with an alcohol and other drug treatment agency, or are we seeing a number of mental health issues where it would be really helpful to bring in a mental health professional. So I think we wouldn't want to burden supervisors with the expectation they have to be the source of all knowledge, but they need to be the facilitators of accessing the knowledge and skills that the people they're supporting might need. Yep.
Which leads to that idea of training for the people who are doing the supervising, doesn't it?
Yes.
Really the intent is to do no harm.
Yes, that's right.
Yes, we're probably all going, that was harmful, or
Yeah.
we remember harmful experiences, and you certainly don't want to see that happening. So there has to be some kind of way for people doing the supervising to have training.
Exactly. Yeah. And we can't do that in the scope of today, but this was intended to be a bit of a, for those who might find it useful, a bit of a reflection on what are we doing in one particular profession, because that's the profession with whom I'm working at the moment. But as has been said, these are really, really broad issues for everyone working with vulnerable families. Yeah.
I think as well the supervision for supervisors, and as you go further up, particularly in line management supervision, the capacity for supervision to maintain that sort of what you might get out of clinical supervision, that's what you might get out of managerial supervision. And I think that as the further up management you go, the less of that you get.
The less reflective it becomes. Oh yes, indeed.
Yeah, but I actually think that model really needs to apply at all levels, particularly in human services and particularly working with complex and vulnerable families, because I think what you'll end up getting is you get a transference of the issues with a supervisor maybe being across, say, 40 families that they're supervising on, for example. And if they're not getting that level of clinical style supervision themselves, then in a sense it starts to affect the quality of what they're going to be able to provide to practitioners on the ground. But I do think that it tends to get watered down.
Yes.
And that the demands to sort of manage up as well as down then become much more difficult in that middle management area to get that sort of genuine reflective supervision.
Yeah, I agree with you. And the encouraging thing is to see people beginning to talk about the importance of the organisational culture and climate in relation to services for vulnerable families. And again, the best researchers in the US, they did a large randomised control on this and found what might not be surprising, that clinical supervision in the way I've described it is a vital intervention for sustaining positive organisational, cultural and climate, and related to lower staff turnover. Some suggestion it may be related to better outcomes for children. That's obviously much harder to assess. So I think we might be beginning to see more attention to this. And coming from a totally different perspective, there's growing interest. A person called Parker Palmer, some of you may have heard of, who is an educationist by background and an American Quaker, so he's drawn a lot on Quakerly practices and brought that to bear in his work around what he would call role and soul, or reconnecting what we do with who we are. So this is not coming from inside the organisation. In fact, it may be at times difficult to do it there, which raises this point about what can be done outside the organisational boundary. But he has, over the last more than a decade, refined ways of working with people across a broad range of professions. This is not with vulnerable families, but it's very much human services in health, education, social services and the like. And inviting people to explore what actually brought them to this work. What was the spark? Huh? And Steve, your point that 50% of us follow our spark into our work, I think is quite fascinating. So I think people are hungry to have conversations about this. And recently in a group, I'll just see what the next slide is to make sure I'm not jumping ahead of myself. That's right, I'm at the right place. The word vocation, the vocation which sustains us in working with vulnerable families. And Parker Palmer is very much happy to use the word vocation, which is a very old-fashioned word. But the definition of which, or the definition which I like, is where the heart's desire meets the world's need. And they're both bits there. It's not just the world's need, it's not just duty, it's where the heart's desire, where the spark connects with the world's need. And so one of the things we did recently in one of the groups of child and family health nurses, in fact it was a new child and family health nurse, but a very experienced nurse, but she was new to child and family health nursing, who looked around the room and saw other nurses who were still in the job 20 years later and still with joy and still with passion and commitment. And I said, do you want to prepare a topic for next time, or do we just want to go with the flow? Mostly they just want to go with the flow, that's fine. But this one said, I'd really like to know how come some of you are still doing this? So I said, well, let's go with that. And so people were invited to prepare for the next time a little reflection on their journey into becoming a child and family health nurse. And you can do this with any professional group. You know, this is totally broad. And it was a very moving session. We went round the room, we took it in turns, which is normally not how we would do it, but every person had an opportunity to speak about their journey, their pathway, their spark. And for some of this was young. This was as children, as adolescents. And not only the journey to, but what sustained them now. And it was profound. People talked about the extraordinary privilege of seeing a family form. These were often midwives. Well, in Victoria they all are midwives, so that they've all helped babies be born. And then they talked about helping a family form when a new baby was born. And there was a real reverence with which these nurses spoke about that, and initially a little bit of apprehension about talking in that way, as if it was a bit, I don't know, because some would say, well, some days it's just a job. And everyone would nod, yeah, some days it's just a job. And then as you went round a bit, people were more open about saying, well, some days it's just a job, and it is a proud profession, but, and there was a searching for the language to say, but when it's at its best, it's a vocation. And it was a really powerful conversation. And I thought, how rarely we have those conversations. We're ending now, so I won't ask you to do it with the person next to you, but I invite you in the next week, if you would like to set yourself the goal of having a conversation with someone, either at work or at home, about your journey to doing what you're doing and what sustains you, around this issue of connecting or reconnecting, if that's the case, what you do with who you are. And I'd like us to get to a point where organisations have that built in so that they're able to provide that level of nourishment and nurture to those working particularly with vulnerable children and families, so that they can sustain that spark in the service of the families. Thank you.